Could be us. So back to what I was saying. Could be us.
పొగ తాగటం, మద్యం సేవించటం ఆరోగ్యానికి హానికరం. స్మోకింగ్, డ్రింకింగ్ ఇంజూరియస్ టు హెల్త్.
Work-related musculoskeletal disorders are injuries or impairment of muscle, nerve, tendons, joints, cartilage, and spine disc caused or aggravated by work conditions and the performance of work. So key characteristics include gradual development. Most of the occupational disorders develop over time due to repeated trauma. Common symptoms include pain, stiffness, swelling, reduced range of motion, muscle tightness, and numbness. Progression. Symptoms often progress from early stage, aching that disappears after work to late stage, and chronic pain that persists at rest. Primary affected areas include lower back, neck, shoulders, hands and wrists. So major causes and risk factors include include two types of factors. One is physical or biomechanical factors, and the other one is organizational psychosocial factors. Coming to the physical and biomechanical factors, one includes the repetitive motion. Next is the forceful exertion like lifting, pushing, pulling heavy loads, and awkward static postures like twisting and bending. And environmental factors include exposure to vibration or cold temperatures. So organizational and psychosocial factors include high workload, tight deadlines and low job control, insufficient rest or recovery periods, and monotonous work. Common occupational conditions in spine is low back pain, lumbar disc herniation, and sciatica. In joints and tendons, it is osteoarthritis, tendinitis, bursitis, and rotator cuff injuries. In nerves, it is carpal tunnel syndrome and cubital tunnel syndrome. How do we screen initially? This includes the rapid upper limb assessment and rapid entire body assessment. These both are the evidence-based ergonomic tools used to evaluate worker postures and identify musculoskeletal disorder risks. Ruler specializes in sedentary tasks, focusing in upper limbs and neck. Rebar evaluates whole body dynamic tasks. Both produce a score of 1 to 7 for Rula and 1 to 11 plus for Reba, determining the necessary intervention levels. So key differences and applications include Rula, it focuses mainly on sedentary tasks, that is sitting works, computer work, assembly, where neck and upper limb loading are prevalent. The scope of examination includes neck, trunk and upper extremities. Scoring is from 1 to 7. So Reba is rapid entire body assessment, focuses designed mainly for dynamic, unpredictable or changing postures often found in healthcare, retail or manual handling tasks. The scope is entire body, and next scoring is 1 to 11 plus. So the assessment process includes the observation, record the workers performing tasks and select the most strained postures for analysis. This is mainly done by taking the workplace video of the patient, of the worker, and then we have to score based on that video. Scoring includes three types, three groups. Group A, it includes trunk, neck and legs, and Group B, upper limbs, lower limbs and wrist. Modifiers are account for load or force, coupling and activity. So final score and actions include negligible risk. Load 1 is negligible risk, 2 to 3 is low risk, 4 to 7 is medium risk, and 8 to 10 is high risk, and 11 plus is very high risk. Based on the risk, we plan for investigation and implement and change of his duties. So benefits includes to identify the hazards and to reduce the injuries and increase productivity. So this is the chart we used to check for upper limb assessment. That is, it includes arm and wrist analysis. In that, we have to check the position of arm, that is 1 plus 2 plus 3 plus based on the number of degrees, from the number of degrees. And step 2, we check for the lower arm position, and then after comparing both the scoring of both step 1 and step 2 according to the chart, we need to look at the wrist positioning and also the wrist twist. The position of wrist, it is neutral or extended or flexed position, whether the patient is while working. This all comes under the when the patient is working in a posture. So if a heavyweight a coal cutter or some employee is working, he will be mostly lying down and taking out the things. So that is the posture we need to evaluate all these things. For lower limb, that is for upper limb, for sitting postures like dumper operator, we need to check these things. And after taking the first, second, and third steps, 4 steps, we need to check in this in the table A, upper arm, the score we have achieved through this. We have to take the score in this, and in the lower arm we need to take the score based on the thing we elicited in the video, in the posture of the patient. Then wrist position, wrist twist, and wrist extension. So we need to check after wrist twist and posture. We need to take the consider the upper arm. If suppose if it is 2 in upper arm, one in lower arm, and wrist test it is 1. So we can take it as 2 in 1 and this. So this is the score we need to take. So based on the 3 positions we need to take the score. So for example, consider this is 2 in this table, and coming to the same in the same way, after reading we need to take the muscle, whether the patient is using the uh, whether the patient is using mainly static or dynamic work. If it is static, if it is dynamic, +1 we need to take. And if additional there is a load, then 0, 1, 2, 3, depending on that we need to add the score, and we need to keep the score ready. And then in the same way we need to take for B and step 9 and step 10 for neck and trunk positions, and also for legs. And we need to see in all the 3 and find out the score. And after that we need to add if there is any muscle score, and along with that additional force or load score. After adding all this, you need to go to the table C and find out the final score, and that is the final score. Based on that we need to, whether it is acceptable or unacceptable, whether it needs investigation or it needs implementation or change, we need to check according to that. So it's a bit lengthy, but by just having the chart and going according to the process, it will be easy to check the positioning of the posture of the patient, and whether he needs any further evaluation for change of his for preventing the problems that is going to arise through the posture. This is almost similar, but it is for lower limb. It includes the lower limb evaluation also. So talking about spine disorders, it includes disc prolapse, sciatic, and spondylosis. Most of them are disc bulges we get, and also in late stages we will be getting the degenerations. So talking about the cervical disc prolapse, some of the red flag signs include upper limb weakness, gait instability and balance issues, numbness and tingling, reflex changes, bowel and bladder dysfunction. So this is what we see in an MRI, and this is the disc that is going to press over the spinal cord. This is what we see in the MRI, and this is the picture depicting the. So clinical examination, it includes sensory, motor, and reflexes. Sensory, it is from C5 to T1. This is upper lateral arm is C5. So then the low in the radial first and 2 digits is the C6. C7 is the middle finger. C8 is the ulnar border of the hand, and T1 is along the medial border of the elbow. So based on this, we check for the sensations, and then we check for C5. It is having deltoid muscle examination. C6 we can do the biceps examination. C7 we can do the triceps examination. C8 it is finger abduction, interossei, and this is dorsal interossei examination, T1. So talking about these are the common tests which we need to check for an suspected case in a OPD. So Sperling test, what we do is we try to, if when the patient is having pain on the affected, for example, right side, we just have to rotate the head to the affected side, and then try to give an axial compression. On doing that, patient will have a nerve root compression, and there will be pain radiated along the nerve, course of the nerve. So another is Hoffman test. In this, we need to hold the middle finger with the examiner holding holding with the other hand with the thumb and middle finger, and try to extend the middle finger at the PIP joint. On doing that, there will be flexion of the thumb and index finger. So followed by that, Lermite sign. It is sudden shock-like sensation when you make the patient to uh, bend forward from head to knees. On doing that, there will be stretching of the spinal cord, and anteriorly there will be compression. So sometimes there will be, in case of severe disc prolapse, patient will be having the radiating pain, current shock-like sensation along the down the neck. So lumbar disc prolapse, it includes sudden loss of sensation of one or both legs, groin or genital area, perianal area, loss of bowel bladder control, inability to walk or stand, sexual organ dysfunction, progressive neurological deficit. So in the same way, generally in the lower limb, in the lumbar spine, nerve root will be exiting above the vertebra. So for L4 it will be above. So L3 L4 disc we have the L4 nerve root compression. L4 L5 disc space will be having the L5 compression, and L5 S1 will be having the S1 compression. And L4 will be supplying the anterior and medial aspect of the thigh and leg of the first till the medial border of the first great toe, and L5 will be on the almost lateral and second toe, first and second medial border of the first and second toe, and S1 it is posterior and lateral border of the leg. So these are the sensory areas which we need to check for these nerve roots, and followed by that, if there is any weakness, we check for L4 it is quadriceps muscle wasting, and for S1 it is gastrocnemius wasting, and then reflexes we check for knee jerk for L4 and ankle jerk at S1. This is straight leg raising test or LASIK test. In this we need to elevate the lower limb with the knee extended and at around 40 to 50 degrees. On doing that, there will be, in case of prolapsed disc, there will be disc compressing the nerve, so that there will be radiating pain along the nerve. So this is a sign to elicit in clinically. Followed by that, spondylosis. This is the spondylosis changes in knees and hips. We check for we call it osteoarthritis. In here we call it as spondylosis. So in follow up in OPD for cervical and lumbar disc herniation, mainly initial assessment we check for confirm the diagnosis, assess neurological deficit, and initial conservative treatment with NSAIDs and short term activity modification. Followed by 2 to 4 weeks of follow up, we evaluate medication effectiveness, pain improvement, and functional status. At critically at week 6 weeks, we check for critical evaluation. Even if it is still persisting, we go for MRI, and final checkpoint by end of 12 weeks. If it is not subsiding, we go for a surgical consultation. So conservative management strategies are physical therapy, medications, activity by avoid overhead activities and intense exercises, and spine orthosis like soft cervical collar and lumbar corset. And cervical and lumbar differences include, subtle difference include, for cervical we can wait for 6 to 8 months, but for lumbar we need to it often resolves faster. However, if symptoms are severe and surgery within 3 days for motor deficits is ideal. If there is any motor deficits, we go for surgery, and by 6 to 12 weeks, if it is persistent, we may even go for surgery, depending on the need. And joint disorders include osteoarthritis of hip and knee, rotator cuff tendinopathy, rotator cuff tears of shoulder, and medial and lateral epicondylitis of elbow, wrist disorders like decurvance, tenosynovitis, carpal tunnel syndrome, chronic heel pain including plantar fasciitis and retrocalcaneal bursitis. So hip and knee osteoarthritis most common mainly due to the joint cartilage wear, thereby causing pain, stiffness, and reduced mobility. Diagnosis is mainly based on X-ray. For hip, there is groin and buttock pain. For knee, it is grating and clicking sensation along with that medial border of knee pain. So these are the pictures. So follow-up in OPD mainly conservative, multidisciplinary conservatory approach. Core pillars of management are patient education, exercise, weight loss, typically complemented by pharmacological agents. Exercise programs mainly by physiotherapy, weight loss, physical and occupational therapy, education and self-management. and assistive devices like cane for hip problems, and braces and patella taping for knee problems, and footwear for pharmacological agents are mainly NSAIDs, tropical NSAIDs, oral NSAIDs, followed by paracetamol, sometimes duloxetine, tramadol, and supplements like glucosamine and carnitine sulfate are not recommended by most guidelines, as evidence doesn't support their routine use. So interventional therapies include intra-articular corticosteroid injections and hyaluronic acid injections and TENS. So intra-articular corticosteroid injections, it gives short-term relief, but long-term it damages more of the cartilage. So hyaluronic acid injections, evidence is controversial with some guidelines recommending against it only for specific cases. So rotator cuff tendinopathy, a common, often chronic shoulder condition causing pain and weakness due to irritation or degeneration of the rotator cuff tendons. It causes pain when lifting the arm overhead or sleeping on the side, often due to repetitive loading, age, or impingement. Treatment primarily involves exercise therapy. So this is the rotator cuff. So infraspinatus, teres minor, supraspinatus, and subscapularis. These four constitute the rotator cuff, along with the biceps tendon being at the in between supraspinatus and subscapularis. It is called the rotator interval. So supraspinatus, this is the supraspinatus. These are the most common areas along the pain along the nerve, pain along the muscle. Infraspinatus, it is posterior to the shoulder, and these are the areas of pain. And subscapularis, it is anterior to the shoulder, but the site is this is the site. And teres minor, it is very low, so very low to the shoulder, posterior and very low. And supraspinatus is the most commonly injured rotator cuff muscle. How do we check it? It is mainly by Job's empty can test. In this, patient raises the arm to 90 degrees in scapular plane with the thumbs down, and an examiner has to apply a downward pressure. On doing so, there will be locking of this bone humerus over the acromion. In between is the supraspinatus tendon. When there is any lesion or bursitis, the test will be positive. So patient will be complaining of. So biceps tendinitis, these are the common areas of biceps tendinitis. So this test is mainly done to check for the proximal end. So in the sitting examiner resists the shoulder forward flexion by the patient while the forearm is in supination and elbow is in extension. So pain in the region of the bicipital groove suggests a disorder of long head of biceps tendon. So common follow-up, common OPD treatments includes rest and activity modification, ice and cold therapy, NSAIDs like painkillers, physical therapy, and corticosteroid injections. So specialized treatments include ultrasonic guided percutaneous irrigation of calcific tendinopathy, extracorporeal shockwave therapy, and platelet-rich plasma injections. So medial and lateral epicondylitis, this is over the outside of the elbow, and this is on the inside of the elbow. So lateral epicondylitis, we call it tennis elbow, and medial epicondylitis, we call it golfer's elbow, mainly due to damage to the tendons connecting to the forearm muscles. On the inner bump, it is golfer's, and outer bump, it is lateral epicondylitis. Both conditions are generally caused by repetitive wrist and forearm movements. We check by doing Cosen's test. Patient is made his fist to extend the wrist while the examiner is resists the wrist extension. On doing so, there will be pain at the lateral epicondyle in case of this is done for lateral epicondylitis. And the same another test, that is polka test. We ask the patient to hold the book in prone position for 15 seconds. On doing so, in prone position there will be lateral epicondylitis. In supine position there is medial epicondylitis. If it is positive, then we can consider the diagnosis. Come to the diagnosis and follow up mainly by rest, rise, physiotherapy, and bracing and taping. Bracing includes the strapping. So medication and other modalities like extracorporeal shock wave therapy and friction massage. Then interventional OPD procedures are steroid injections, platelet-rich plasma or autologous blood injections, tendon needling or fenestration. Under ultrasound guidance, the tender area is needled 20 to 30 times to induce an inflammatory healing response, and another is botulinum injection, toxin injection. So carpal tunnel syndrome, it is mainly due to compression of the median nerve at the wrist. This is the picture showing the median nerve course and this is the supply, and this is the part where there is compression of the there is area of numbness and pain. So symptoms include numbness, pain, weakness, and on shaking, patient will be having relief. So patient will try to shake the hand whenever there is a he feels. So causes mainly includes median nerve compression. Sometimes in gout and other infections there is inflammation and swelling. Repetitive motions, mainly in the hand tools, frequent use of hand tools that vibrate or repetitive forceful hand and wrist movements, and anatomical factors like old fractures or dislocations. So follow up mainly by splinting, medication, injections and activity modifications. So decurvence, another painful condition mainly due to inflammation of the tendon sheath, and symptoms include tenderness, swelling and reduced grip strength. So follow up mainly by checking, doing this maneuver, thumb is so upon ulnar deviating the wrist, there will be stretching of the tendon sheath where a patient will be complaining of pain. So treatment mainly by immobilization, medical intervention includes steroid injection, and chronic heel pain. This includes heel pad atrophy or bruise, tarsal tunnel syndrome, Achilles tendonitis, plantar fasciitis, and stress fractures. So follow up home remedies, stretching exercises, footwear support, using a cushioned soles, and adding orthotic inserts. Medical intervention and long-term strategy by managing body weight and transitioning to low-impact exercise like swimming and cycling. So role of physiotherapy: pain management rehabilitation, mainly by manual therapy, uses hands-on technique like joint mobilization, soft tissue manipulation, and spinal manipulation to reduce muscle tension and improve flexibility. Targeted exercises by implementing specific progressive exercises to strengthen core muscle support, the spine and stabilize joints. Modalities like TENS, ultrasound, heat and cold therapy, and hydrotherapy uses water-based exercises to reduce stress on joints and aid mobility in severe cases. Mainly, the role of physiotherapy is for rehabilitation, pain management, improving mobility and flexibility, preventing injury and disability, and managing chronic conditions. So, concept of open versus closed chain. So, in open versus closed chain, exercises involve movement of the distal segment is free to move in space, allowing for muscle isolation. So, in open kinetic chain, the distal segments will be mobile. In closed kinetic chain, the distal will be fixed. So this is an example showing closed kinematic where the distal segment is fixed and the proximal is mobile. In open kinematic, distal is mobile. So this is characterized by open is characterized for mobility, and this is for stability and power. So these are some examples showing the types of exercises. So manual therapy, it includes traction therapy. Use mechanical force to stretch the spine and alleviate pressure on compressed nerves caused by protrusion of the disc. When we apply pressure, traction is applied, there will be decompression at the disc, creating a negative pressure within the disc, allowing water, oxygen, and nutrients to be reabsorbed, and thereby there will be relief of pain by relieving disc pressure. So targeted exercise. These are some of the targeted exercises showing the for prolapsed intervertebral discs and neck exercises. So some are arm bench exercises and straight leg raising exercises. For side bend exercises, shoulder shrug, neck rotation, wingspan, back and forward bending. And one more thing is carrying heavy weights can put excess strain on your spine and back muscles, causing or aggravating back injuries. So during at the workplace, this is the thing they have to follow. The spine should be straight, and while bending, most of the weight should be taken by uh, by the limbs, knees, and weight should be kept near to the body and avoid overlifting and overbending forward. And do's and don'ts include: if it is too heavy, you have to take a team, and do not turn around while carrying the weights, and try to lift with your legs. And if it is too heavy, use an equipment to take it, and avoid using taking heavy loads or bending too much forward and rotations. So these are some exercises pertaining to hip and knee, like straight leg raising, pelvis lift, supine hip bridging, and these are some of the quadriceps, sitting quadriceps, straight leg raising, standing and abduction of hip exercises. Some exercises for hip and knee OA. These are for pictures showing the rotator cuff exercises. So medial and lateral epicondylitis, mostly we do, this is a physiotherapy protocol we do, eccentric wrist extension, wrist flexion, forearm pronation and supination, grip strength, forearm strengthening, raise elbow flexion and extension, and mid strap exercise. So for carpal tunnel, we check for opposition carpal tunnel decurvators, wrist stretch, wrist flexion, wrist radial and radial deviation strengthening, wrist extension, grip strength, and finger strength. For carpal tunnel, there is one more exercise, that is flexor tendon gliding exercise. Perform each position for 5 seconds, 5 repetitions, 5 times every day. That is from neutral position to hook position, then to fist, then to tablespoon, then straight fist. So this is one exercise. Generally, we don't advise, but it needs to be known. And heel spur exercises, big toe stretch, squat calf stretch against the wall, seated calf stretch with a towel, downward dog pedals, golf ball foot roll, and plantar flexion with resistance band. So modalities include TENS. There is a pain pathway. These are C fibers and A beta fibers. These are the non-myelinated fibers. These are the myelinated fibers. So myelinated fibers have the more speed compared to the type C fibers. So for type C fibers, the main pain pathway is type C to the pain gate neuron, then to the brain. But when we give an external stimulus to the A beta fibers, that is using a TENS or IFT or SWD, short wave diathermy, what will happen is there will be stimulus from this nerve to stimulate this one, thereby preventing it to depolarize this nerve. So upon that, this response will be cut and this will be taken. As a result, there will be endorphin release mechanism, natural pain relieving chemicals. So IFT include same with pain gate control and vasodilatation by increasing blood flow, reduction of edema, and stimulation of endorphins. In IFT, what we do is we take 2 electrodes with 4000 and 4100 in perpendicular, and we try to get an offbeat of 100 millihertz. On doing that, there will be vasodilatation. There will be vasodilatation, reduction of edema, and stimulation of endorphins. So when not to use IFT and TENS, it's mainly when there is pacemakers on metal implants, pregnancy, and skin sensitivity. So these are the sites for TENS, and this is for IFT. So ultrasonic therapy, for 1 millihertz, we get a deeper penetration. For 3 millihertz, we get a superficial penetration. Based on that, we can do an alternating 1 and 3 megahertz. This helps benefit increase blood flow, reduce swelling, and decrease muscle spasm and improve tissue extensibility. So this is a photo showing the ultrasonic therapy. And shortwave diathermy, it includes 2. So in this, the high frequency alternating electric current flows from one plate to other through the patient. So from the here to here in this way. Upon doing that, there will be deeper tissue heating, and that converts electromagnetic energy into thermal energy to treat pain and improve healing. So there is a specific frequency we use, that is 27.12 millihertz, to deliver deep heat of 3 to 5 centimeters. So hydrotherapy. In hydrotherapy, it's a rehabilitation method using warm water pools, that is 30 to 36 degrees centigrade, to leverage buoyancy and hydrostatic pressure. It reduces joint loading, pain, and swelling, while providing resistance to improve strength, mobility, and balance. So if it is immersed to this level, we get 15% body weight reduction. If it is still thigh, that is 35%. If it is still waist, 50%. If it is still chest, 75%. And if it is still neck, it is 90% weight reduction. So key aspects of aquatic therapy are buoyancy, and buoyancy supports body weight, reduce impact on joints, which allows earlier, safer movement compared to land. Hydrostatic pressure helps reduce edema, swelling, and aids circulation. Warmth, the heated water increases blood flow, reduces muscle spasms, and aids in pain relief. Resistance, water provides natural resistance for strengthening muscles. And how to avoid all these occupational spine and joint disorders in underground coal workers. This focus mainly on implementing ergonomic interventions like using mechanical assist devices for heavy lifting, redesigning workspaces to minimize awkward postures, specifically kneeling and bending, improving seat design to reduce whole body vibration, and training workers in proper safe lifting techniques. Key strategies to prevent musculoskeletal disorders include ergonomic interventions. Ergonomically, we implement by mechanized lifting, pushing, and pulling aids to reduce physical strain, as constant lifting causes long-term back and neck damage. Postural training train workers to avoid prolonged deep knee bending, and static low ceiling postures. Utilize but frequently rotate from kneeling positions to prevent meniscus strains. Vibration reduction: install improved vibration dampened seats in shuttle cars and mining machinery to minimize exposure to harmful whole body vibration. Physical conditioning: implement exercise programs designed for miners to strengthen the core, back, and joints. Job safety analysis: conduct regular uh, job safety analysis to identify and mitigate risks associated with specific demand tasks. Manual handling techniques: train workers on proper lifting, pushing, and pulling techniques to reduce spinal strain. Mechanical assistance: utilize lift trucks, conveyors, and mechanical aids to move heavy materials, limiting manual handling. Key risk factors to address are repetitive strain, whole body vibration, and manual material handling. By reducing these risk factors, and using proper protective measures, coal miners are significantly reduce the risk of spinal and joint disorders. Thank you.